We will start the meeting. We will start the meeting with a silent prayer. Thank you. Good evening to dear all. I know that it may be good morning to some other parts of the world because this is a hybrid platform. I welcome you all, our respected chief guest, Professor Kichu Nair, my respected teachers, and my dear friends. It's my privilege to welcome you all to this academic activity, the Day of the Geriatrics, by the V.C. Mathiru Academy. V.C. Mathiru Academy is the academic wing of the Thiruvananthapuram Medical College Alumni Association, founded after the legendary medical teacher, Professor V.C. Mathiru. And the context of today's meeting is that we are initiating the PG in Geriatrics in Thiruvananthapuram Medical College. You know, geriatrics is gaining importance. The demography is changing in the country and more so in the state. And we need to pay more attention to the medical problems of the geriatric people. And geriatrics is a subject which is close to Professor V.C. Mathiru. So, today, this academic activity has got three portions. The first is the oration, named after Mathiru sir. And the second will be a panel discussion on the unmet needs, the unmet geriatric needs in the state. And the third will be an informal open house discussion. I request all the faculty and speakers to stick to time. This is a 1 hour activity. And with these words, I welcome each and every person, our chief guest, my respected teachers, the faculty, the students, and my friends world over. So thank you very much. And I invite our principal, Dr. Lynette Morris, for a brief message.
Respected senior faculty members, respected colleagues and students, it's indeed a privilege to be here in this August gathering as we start the master classes, and to initiate that we have Professor Dr. Kichu Nair, who is also an alumni of Thiruvananthapuram Medical College, to enlighten us on the topic of geriatrics. As we all know, geriatrics is gaining much popularity in Kerala with all the youngsters leaving the state, and we are left with a population of geriatrics. So I know we are all of you are eagerly looking forward to this academic feast. And as I welcome sir to this topic, I welcome each and every one of you to this academic gathering. Thank you.
It's my privilege to welcome all of you, your attention and presence to the prestigious V.C. Mathiru Oration. Professor V.C. Mathiru is a legendary teacher, and he is actually an inspirational presence to the globally extended Thiruvananthapuram Medical College alumni. There are many firsts which are attached to Professor V.C. Matthew Roy. He is the first MD graduate, medical postgraduate from the state. And then he started the diabetic clinic first in the state. He established the first endocrinology department in the state, and many others. After his post-graduation, he went to UK, as many of his predecessors have done. And after adequate training, and unlike many other predecessors, he opted to come back recharged and inspire generations of students here. He ruled the academic campus here in 70s and 80s with a sort of rare fire in the belly, with the kindness in the heart, and that awesome knowledge in his upper story, till his untimely demise, unexpected demise in 1987. His main topics of interest were geriatrics, endocrinology, and rheumatology, the gray areas at that time in the country and the state, and I believe even now. So it's really a fitting tribute that we are conducting this oration on geriatric topic upon his memory. I cannot actually think in terms of any other medical teacher with whom so much of narrations and stories are attached in the minds of his colleagues, generations of his students, and even the patients. Patient perspectives are very important. And some of the stories told by the patients are quite incredible. And I can tell you that many of the youngsters may not even believe that such a doctor ever existed here in Trivandrum. So I would like to state that the Academy would like to compile these stories and narrations about Matthew Roy sir, the beloved memories, and I would like to compile something like a coffee table sort of book and publish that. So coming back to the oration, it's very difficult to find a deserving orator, a speaker, to an oration with that sort of a hype. But then we are very fortunate this time to get a speaker. We are satisfied, we are very happy with Professor Kichu Nair, Newcastle from Australia. He is an alumnus of this college, and he is a proud student of V.C. Matthew Roy sir. And just like Matthew Roy sir, he is an academician, he is a leader in his own right, and ticks all the boxes and beyond of the expectations of the search committee. So we are fortunate to have you here. And to introduce the speaker, I would like to invite Chairperson Krishnamurthy sir, who is a colleague of Matthew Roy sir, and the speaker here. So thank you, sir. And introduce the speaker, sir, and adorn the medallion. Thank you, sir.
Dear friends, Dr. Matthew Roy was part of me really during my curriculum throughout. When I was final year, he was the MD student. He's a magnetic man. You speak to him, meet him, all the way. Lifetime you would like to see him again and again, talk to him or learn something from him. He was always distinctive. In academic, he was the first man to get MD from Thiruvananthapuram Medical College. It was not easy to get MD, even though You complete the course, all of them go outside and get. Fortunately, working with him, I am the first person to get MD degree, first chance in Thiruvananthapuram Medical College as a clinical tutor. Tutors can write exam. Then academic activities, I think, has been shown. He was an excellent sportsman. If we go for basketball, the whole medical college will be there to see him. That was his talent, that was his knack, that was everything. Then about the research, we did not say anything. He publishes everything all around topics. The first dialysis PD in snake bites, I published with him in Kerala Medical Journal. That is the criteria for treating snake bites even now. I was close to the family. His father, I have seen him for some. He won't treat his father, So when he has got some breathing problems or something, he asks me, he has just like us, we don't know how to treat our relatives. So that he lives all the way, all the time, in everything I do. Perhaps somebody who has seen him before. Regarding Kichu Nair, MBBS from here, MRCP, FRCP, Australian FRCP. He is the head of the geriatric medicine. He has got other activities like, do we have next slide or no? Leadership, he makes people leaders. Medical Council examiner, Director of Evaluation of Health Education Training Institute. He's the editor of Chief Journals. Yes, textbooks. His textbook is coming out. Is it there already?
No, that's out, but other one is coming out.
So when you will leave a textbook for our alumni, please. Then the publications, research funding. I think top physician or doctor would like to have all these achievements and continue to contribute developments and his application to our medical college, his own college, first college, we'll appreciate, we'll think that he will give guidance for all our students to what to do if they would like to come to Australia. Welcome, Dr. Pichu. Thank you. Thank you.
Thank you very much. I tried to talk from here. Will you get the audience okay? Yeah. And I'm trying to see whether. Yeah. Okay. Thank you very much. It's an honor and a privilege to deliver Professor Matthew Roy Oration. I was an undergraduate student with him in year 3. And in fact, he was one of the most brilliant clinicians I have seen. So he was my role model then. And Professor Pai was the head of the unit and Matthew Roy was assistant professor when I was there. Then I did internship here in Thiruvananthapuram and senior house surgery before I went to UK. And I again looked up to him as the most brilliant doctor I've seen, even overseas. He's somebody, he was very brilliant as a clinician. He could auscultate and pick up a diastolic rumble of mitral stenosis, then see the next patient, look at the fundus and say there's papilledema, and then examine the patient and diagnose a brain tumor. This is all before there were cardiac echoes and CT scans here. So he was my role model. He was a shrewd clinician, expert in diagnosing, as we heard, And he also a very stimulating teacher. He had the leadership qualities we heard, and he worked with the team members too. That's again part of being a doctor these days. He'll be happy to know that we are talking about the holistic care of our older patient with multi-morbidities today. So I will try to justify his legacy and talk to you about what we should be doing in Trivandrum to look after older patients. Could I have the first slide? I can move the slide here. Okay. Okay. So I'm very much interested in medical history, because history teaches us where we come from, where we are now, and where we should be going. Even simple things like penicillin. Before penicillin, people died of pneumonia. With penicillin, pneumonia became a very curable disease. Then what happened? We started to overuse antibiotics. Now we are looking to stop people using inappropriate antibiotics. We have antibiotic stewardship now. Similarly, even in personal things, it's the same. So history will teach us where we were, where we should be, and where we should be going. So in the next few slides, I'll try to impress you that what we should be doing. Next slide. I can move it here? Yeah. So somebody has defined aging is a major challenge for the world now. Some people say this is as important as global warming or terrorism, because this will define economies of the world. There's a concept called dependency ratio. Dependency ratio is the ratio of people who are working to pay the taxes. For example, people from the age of 18 to 65 will be working and paying for the taxes to build our hospitals and support the infrastructure of the country. So the challenge now is that more and more older people are there in the world, less and less younger people are there. So dependency ratio is shifting. So we will be challenged with this. And again, with the aging of the population, that also can theoretically put stress on the healthcare system. So aging is a global issue. Most of the developing countries thought aging is an only issue for developed countries. But if you look at 75% of older people now live in developing countries. When you look at the absolute number of older people, UK or USA or Australia, we have very small number of older people. The majority of older people are living in developing countries. So that's a global issue. And people always say aging is a tsunami. I disagree. Tsunami comes without any warning. We knew this was coming for a long time, at least 50 or 60 years. So we haven't done anything. So it's time to wake up and do something. Thank you. Next slide, please. So aging is a hallmark of the 21st century now. People realize it. I know there are a lot of specialists here. If you're a renal specialist or an oncologist, your patients, one issue will be oncology or renal, but they all come with multi-morbidity. The average 70-year-old patient now has at least 3 comorbidities. If you have 3 comorbidities, you're going to take at least 5 tablets, 5 medications. So that's a challenge. So what happens is when people come to, I'll discuss this in a while. While people come to see the doctor, they get the one single disease sorted out. The rest is left to somebody else. So we don't have that holistic approach like Professor Matthew Roy had. So that's what we should be doing. Next slide, please. So this is the population aging. So the population aging started something like in the 1950s, and then gradually it's going up. For example, in Australia now the life expectancy at birth is 84 years now. But if you look at in 1,900, 124 years ago, life expectancy at birth in Australia was 47. Same thing with India. So we have the challenge of looking after older patients, and the question is, are we doing the right stuff? Are we doing the right thing? Okay, thanks. So this is the population pyramid. This is the world population. When you look at the 1950s, you can see the population as the aging goes up. The population is like a pyramid. This is called the population pyramid. Why? Because we have more babies born and not many babies survive to live to old age. You with me? So, but if you look at 2017, that is, the pyramid is gradually shifting. By prediction of, by 2050, the population can even become a rectangular at the extreme case. So if you look at the population now, we have less babies born in every family, and they all survive because we have triumphed in looking after young babies. People like you would have done amazing work. And so less babies are born and all of them survive to old age. So that's our biggest challenge now. Next slide, please. Same thing in Australia, that's Australia in 1950s, 2017 and 2050. The pyramids bulging in the middle. What about India? Next slide, please. That's the Indian population in 1950, 2017, and prediction for 2050. Again, the pyramid is gradually shifting. So I hope I've convinced you we need to do something about this, the aging population. In fact, aging is a side effect of good public health measures, reducing infant mortality and everything else. But the question is, have we done enough for this population now? Next slide, please. Okay. But the trouble is, older people are the most heterogeneous population you can see. If you, in Australia, if you are 65, you have at least another 20 years to live. So that will be a very heterogeneous population. There are people who are fully independent and go bike riding. There are people in nursing homes, people who need home help to stay at home. Whereas if you are up to the age of 18, you have neonatology, you have pediatrics, you have adolescent medicine. We don't have any specialized care for our aging population. Yes, please. Next slide, please. So, we are talking about the world population. What happens in our own backyard? What happens in Asia, Asia Pacific? Japan, now the life expectancy is 86.4. There are a lot of reasons. If we have time, we can talk about it. Australia is 84. India is 69 according to this figure. Life expectancy. Most of the developing countries. The only chronic diseases to manage in older age group. Most of the developing countries, the trouble is they have to manage chronic diseases. At the same time, they have all the other infectious diseases like TB and everything else, filariasis and everything else will come with infection and other things too. So they have this so-called double whammy because they have to manage the infectious diseases and chronic diseases too. So it puts a bigger burden on our economies in developing countries. So that is a major issue. And again, we can talk about compressing morbidity if you have time, later on. Yes. Okay, next slide, please. Maybe I'll go to the next slide. Thank you. Because, So this is the actuarial table. This is taken from insurance data. For example, we know the life expectancy at birth in Australia is 84. But what happens when you reach the age of 84? This comes from actuarial tables. If you reach the age of 84, you have another 7 and 8 years to live, 7 to 8 years to live. So when you see an 84-year-old person in Australia, the question is not to ask, okay, you have done your bit, so see you later. What you have to say is this person has another 8 years to live and look after them. So never ask a patient his chronological age. See what's the quality and how much they have to live. If you're 100, you have another 2 years to live. So we need to plan their treatment according to what's the quality of life and how long they have to live. Okay, next slide, please. Okay, now we said we start from history. This is Dr. Marjorie Warren. You can go to the next slide, please. She was trained as a surgeon. And because she was a female and they want to delegate her elsewhere, they sent her to look after a chronic ward. This in 1940s. She had something like 714 chronic long-stay patients in a hospital then. What she did was what geriatricians do now. She took history from them, examined them, rehabilitated them. And in 2 years' time, she was able to discharge a lot of them home. And the hospital became a patient's hospital for only 200 patients. So she was the mother of geriatric medicine, maybe in the world and certainly in the UK. Next slide, please. So I might skip that slide. I'll go to the next one. Yeah. So this is what she said in 1946. The question you have to think is, what have we done, what you have done so far? Okay. She said geriatrics as a specialty compared to pediatrics. It needs a specialized training because, you know, physiology is different in older patients. You need to know that physiology and you need to have the training. So she said creation of a specialty like you're trying to do now will stimulate learning and stimulate research. This we should be teaching medical students and even postgraduates. And we need research too. We just finishing a huge research on dementia. We had $3.4 million competitive research funding. We're just finishing a 5-year study. Research takes time and you also need money. So she said these things in 1940s. And we are still lagging behind in Australia. Okay, next slide, please. So next man who popularized and pioneered geriatrics is Professor Bernard Isaacs. He was a famous geriatrician from Birmingham. Next slide, please. He's the one who coined the 5 I's, I as in I, letter I, of geriatric medicine. Immobility. When you are getting older, you become immobile. Again, no point in saying somebody is immobile. You have to say why they are immobile. He said because they have Parkinson's disease, they have multi-infarction, or they have osteoarthritis. And older people also hate when you see them and say it's an old age. The good example is we had a patient who came with pain and osteoarthritis in the right knee. And the specialist said, oh, that's old age. He said, but my left knee is also same age as my right knee. I don't have pain there. What the hell is going on? So patients are clever too. They want you to tell them what's wrong with them. So immobility is very common. Other instability, falls. 30% of our patients who come to our emergency department come because they had a fall. It could be in the kitchen, in the living room, or in the shopping center. And then when they come in, they have a fractured neck of femur, usually, because they don't have osteoporosis treated properly. Incontinence. Something like 30% of community dwelling older people are urinary incontinence. Could be very minor stress incontinence. Obviously, it may not cause physical death, but people say it causes social death. They don't want to go out. So that's very common. Impaired cognition. In Australia, we think something like 2.5% of older people, when it's older, 65 is older now by definition. I don't agree with that. And 2.5% of people have dementia. And it doubles every 5 years. So if you're 70, 5% of people will have dementia. If you're 75, it goes higher. So dementia is very common. Even in Australia now, the lag time between the onset of dementia and diagnosis is 3.1 years. So there's still, we don't diagnose it appropriately and in timely fashion. Iatrogenesis, that's what we create. Because we know by old age physiology, there are changes in how the body handles the medication and how the body works at the receptor. Pharmacodynamics, pharmacokinetics. The same dose of gentamicin you don't give to an older person. Or if you give somebody a warfarin, the effect of warfarin in the receptor side is different. So you need to know your pharmacology. So polypharmacy is very common. Polypharmacy is if you take more than, by definition, 5 medications. But then if you don't need any medication, if you take one drug, that itself is polypharmacy. We see a lot of older people taking benzodiazepine for sleeping. That's another story. And then they fall down and come to the hospital and they get addicted because there are again benzodiazepine receptors. So what if you see an older person, you have to do a very comprehensive assessment. And we don't do it. Thanks. Next slide, please. This is Professor James Williamson. He was professor of geriatric medicine in Liverpool, and I was his resident. Then he became professor of geriatric medicine in Edinburgh. He was very much into doing a proper assessment of older patients. Next slide, please. So they published a paper in 1964. They're looking at older people living at home. They were surprised to see the number of undetected or undiagnosed conditions they had. If you have cardiac failure, you might know. But you have painful foot or plantar fasciitis, you never knew. That's what caused them to have difficulty in walking and falling down. So he published this paper in 64. And again, that's one of the first time they looked at the unmet needs of older people. The question is again, what have you done so far? Next slide, please. Okay, so I think we discussed this. I think again, 2024, nobody can work in isolation. Even if you are the most brilliant cardiac surgeon, you need a team. So any complex medical care on an older patient, you need an interdisciplinary, multidisciplinary approach. And we don't do that properly. Next slide, please. So just let's talking about evidence-based medicine and precision-based medicine. So we said that 60% of older people will have more than 3 chronic conditions. In fact, when people are always arguing now and say the commonest condition we all treat is multimorbidity, not renal failure, not cancer or the pancreas. Everybody has multimorbidity. Even if you come with renal impairment, you have hypertension, you have uncontrolled diabetes, you have hyperlipidemia, you also have some minor cognitive impairment. But we don't look at the whole patient in a holistic manner. Okay? The other thing is we talk about evidence-based medicine. Evidence-based medicine is a concept I used to teach and I still teach. But evidence-based medicine is good if you have one single disease. For example, if you have atrial fibrillation, we know they should be given anticoagulation. But if you have dementia or if you have a fall or if you have chronic renal failure, you do not get into a randomized control trial to get evidence-based medicine. So this way we push for now a concept called medicine-based evidence. You know, what happens if you, an older lady with atrial fibrillation who should be given warfarin or apixaban, but who has got a renal failure, she has mild dementia, forgets to take tablets and at other 5 comorbidities. So we're talking now about evidence-based medicine to medicine-based evidence too. Because if you're an older patient and if the patient has multi-morbidity, they don't get into any randomized controlled trials. You with me? So we don't have a lot of evidence. Sometimes you're talking from experience. One of the other things also, people talk about frailty now. Frailty is, if you see a frail patient, you know, their gait speed is low, they have lost weight, they look very frail. And there's a lot of clinical definition for frailty. The other thing people don't talk about is sarcopenia. We talk about osteoporosis and loss of bone density. But again, as older patients become older, they lose their muscle mass. So if they come to hospital and put them in bed rest for 2 weeks, by the time they get ready to go home, they can't walk. Very common. When they come to hospitals, we create a problem sometimes. Okay, sarcopenia is very, very common. We discuss cognitive frailty. We don't have time to talk about these things. What I'm trying to impress on you is we need to have a holistic approach and look at everything the patient comes with. And they don't come with, then you have to be proactive. For example, we did a large study of a health visitor going and seeing patients at home. We had something like $1.6 million grant to do a proper randomized control trial. The randomized intervention was a trained nurse or occupational therapist going and looking at the patient at home, looked at the medication usage, false risk, incontinence, cognition, everything. And after 2 years, we found out those people had much better quality of life. They lived longer. And we also found that by the intervention and assessment, they had more medical intervention. So they did much better. And then based on our research, the Medicare in Australia brought a new provider number. So that means a GP that went to a family doctor, they get $200 to do an 1 hour assessment on the older patient. So some of the research we have done created an impact on the healthcare system. Next slide, please. So the Canadians have come up with this. We discussed the I's of geriatric medicine, I. Canadians have come with the 5 M's of geriatrics for all patients. What's M? For the mind. Okay, older people, we said, may have dementia. Some of them are lonely and they feel depressed. They also have delirium or acute confusion when they come to hospital, or they have an urinary tract infection. So the mind is very important for all the patient, and we need to do that M assessment. Mobility we mentioned, multi-morbidity we mentioned, because nobody comes with single disease. Medication we discussed. The other thing is also what matters to the patient. For example, we may have a patient with a pancreatic cancer. The doctor wants to treat. The patient may not want to treat. So what do? They have their say too. So what matters to the patient is important, and often we don't do it. And we even tell people with dementia, at the time of diagnosis, just write down your advanced care planning. If you have pneumonia, you want to go to hospital, or you want to be kept comfy at home with oxygen surrounded by your family, or you want to go to an ICU, get all the intravenous medications, ventilated, still the outcome would be the same. So a lot of older people now elect to have quality of life than quantity of life. As President Kennedy said, our aim should be add life to years, not years to life. Okay, so that's very important. And what matters to them is very important. So I think you mentioned the textbook series we are coming out with to Spring and Nature. So the series will be based on the M's of old age. Next slide, please. I think we just skip it. Okay, so I think we mentioned there's a big debate. When does aging start? Any comments? At birth. And we can do a lot of things from birth to prevent and compressing morbidity. and disability. We don't do it. We know that at the age of 30, most of our physiology is 100%, the best physiology. But if you look at renal function, from the age of 30, you have gradual decline in your creatinine clearance. And we also know that creatinine depends on your muscle mass, we mentioned. So if you have an older person with a normal creatinine, they may still have significant renal impairment. We don't look at it, and we don't train people to look at the renal clearance by Cockcroft-Gault equation. We don't do it properly. So I think we just go back to, yeah. In the next, previous, okay. So that is, so we can, at certain levels, we can intervene and get the patient the right treatment and get them better. But then there's a gradual decline. So we need to decide when we want to intervene and what we should be doing, like we discussed. Okay, next slide, please. So can we do anything about, this is telomerase. How many people know about telomere shortening? Okay, some people know. Okay, good. So this is the work done by Elizabeth Blackburn. She got the Nobel Prize in Physiology and Medicine in 2009. She's an Australian, now located in California. So we all are born with a lot of telomeres, which are essential at the end of the chromosome for cell replication. Cells have to divide in telomeres. As we get older, the telomeres become very, very, very short. And by the age of 65, your numbers have gone down. So this is why we have programmed cell death and people get older. In a very interesting book she wrote, she said about mind your telomeres. What can you do to keep them going? And she came up with this idea of, compassion, empathy, meditation, good food, exercise, omega fats. So we can postpone aging by doing the right stuff. And that way we are compressing morbidity at the end of your lifespan. Okay, next slide, please. So just last 2 or 3 minutes, there are very, very new models of care in geriatrics too. I said, one of the first things we start is in orthopedics. As older patients come with osteoporosis and falls, they have usually a fractured neck of femur, and then they end up either dying or they end up going to nursing homes in Australia. So the first model is when a patient comes with a fractured neck of femur, if the patient is managed by geriatric team with orthopedic input, patient will get better and go home. Because you intervene and looked after the atrial fibrillation, cardiac failure, manage your diabetes mellitus. So the outcome is good. In our surgical wards, most of the patients are in the 70s and 80s. And all of them need multidisciplinary input and medical care. So we did a pilot of geriatrician doing rounds with patients coming with acute cholecystitis or a bowel obstruction. And we saved a lot of money and quality of life, improved quality of life for patients. So there are lots of models. And I mentioned about, in Australia now we have the 75 plus assessment. Anybody above the age of 75 get a full 1 hour from a general practitioner looking at all those 5S or 5 I's I mentioned. So patients are relying on their doctors to do a more comprehensive assessment. So next slide, that may be my last slide. Next slide, please. So we mentioned and we said, no, we are going to the other. 20th century was a century of acute disease. Okay, in 20th century, we have good treatment for myocardial infarction. We thrombolize patients with stroke even before they come to hospital. Some people get thrombolized in the ambulance. So their outcome is good. And we treat high cholesterol, we treat blood pressure, we treat acute infection. The 21st century is a century for chronic diseases. We need to shift our mindset to do the right stuff by the patient and the population. We don't do it. And So there's a saying, okay, we go to the last slide. This is me. Okay. So what happened is we had a patient, this is the last slide. We had a patient, I had a patient who came in with a fractured neck of femur. Very healthy lady. First time she came to hospital. And she had diabetes. She was on metformin. And when she came in the hospital with a fractured neck of femur, in the orthopedic ward, she developed acute renal failure, the dehydration. And she had lactic acidosis when she had kidney failure. Normally, a lady like this will get the treatment, orthopedic fracture fixed, and go home in 10 days' time usually. This lady developed acute renal failure, lactic acidosis, ended up in having dialysis in ICU, stayed for 58 days. We spent thousands of dollars to look after this lady. So we said, if the system is not fit for purpose, we need to change the system. If we can't look after all the patients properly, we need to change the patient flow and we need to treat them properly. So based on our work, that's me and my registrar, and the Medical Journal of Australia came out with a supplement to see how we need to reorient and restructure the healthcare system. So if Professor Matthew Roy was here, he would have told you, is it time to look at the patient in a holistic way? We need to look after all the patients with multi-morbidity, with a multidisciplinary team. And if people are not trained, we need to train them properly, and we need to do the right thing for our patient. So he will be very proud. At least you're starting the dialogue now, and you're doing the right stuff now. Thank you very much.
Thank you, Professor Nair, for the excellent oration. You have set the stage right for our PG program in geriatrics. Thank you very much, and you've taken the oration to the level beyond our expectations. Please give a big round of applause and a standing ovation for Professor Nair.
Thank you very much.
And now, well, we would like to award the oration. Okay, so I would request, sir. No, I think the plaque is there. Officially, will be awarded. And I would like to Professor Vasudev, the Vice Chairman of the Academy, to join for the award. Our vibrant president, Dr. John Panikkar, will be joining us and he'll be addressing it. And next will be the panel discussion on the geriatric practice and its unmet needs. And I would request. I would request Professor M. Kirsi Nair to moderate the panel discussion, and but we can invite the panelists also. So the chairpersons and the panelists will be invited. So I think he has given me the privilege to invite the chairpersons and the audience for the panel discussion. The chairpersons. Okay. I think, well, Thomas, Dr. Srinath is there, Dr. Srinath. And the panelists, please, Dr. Aruna, HOD Medicine. Rajagopal sir, please come, yeah. And Professor Nayak himself, please come. Yeah.
Good afternoon, good evening, friends. I'm not well, that's why I was trying to escape, but he won't let me because I can't speak. I have some problem, throat problem. But the session is so interesting, so we need to have a lot of discussions. We don't have a structured program. All the people sitting here, at least majority of them are eminent professors doing of medicine or related subjects. Kashi sir is here, so many others are there. So I think I'll only kick off the discussion from one end to other end. When you don't know what to do, we always say you start with a physical, mental, social, psychological, ethical, etc. So shall we start with an ethical one? Does that work, sir? Or each one can talk, whichever you are comfortable. You start with it.
We always learn and teach ethics, guided by the ethical principles that have been put up globally, sometimes without really mindful of what are the realities here in our country. But not only in our country, by the way, the low and middle income countries form 84% of the global population. We are guided by research and findings from 16% of the global population. Often we do not know our own problems. When you ask me to talk about ethics, I am not going to talk about autonomy, beneficence, non-maleficence, or social distributive justice. I am talking about the failure of the health system to look at the realities around us. This morning, I visited a family in Murukumbura, suburbs of Trivandrum. The man had cancer 22 years back, treated with radiation and chemotherapy, and now considered cured. Isn't that fantastic? Great. That we could achieve. Dr. Jayaprakash is here. This was done in our regional cancer center. Great. He is unable to get up and walk, not because of that. His diabetes has never been under control. Today when we went to his home and checked, it was 252. That's a dramatic improvement from 543 that last month. When we go out into the community, we see people being denied care for diabetes and hypertension, left totally uncontrolled. And that's happening to the vast majority of people. People with disabilities are left lying there with pressure sores. We never see them in the hospitals. They don't get to us. They'll never get to us. The medicines availability has improved a lot in private government hospitals, but they do not reach these people. It will stay in the hospital. Some people will access it. The most needy will not access it. And Dr. Kichu, you talked about that evaluation model, including psychosocial. 23. During the monsoon, I saw a man with advanced cancer sitting and holding an umbrella inside his home because the whole roof was leaking. When we talk about ethics, please let me complete this sentence and I will stop. When we talk about ethics, we have to see how our health system fails to see the people around us. Not far away, we are not talking about the Bimaru states, we are talking about here in Kerala.
No, sir. What I was trying to say is, can you summarize the whole ethics into 3 points? Just 3 points. What are the 3 points you believe is so important, ethical aspects? Just 3 points.
Dr. MKC, you possibly have a very clear idea of what the 3 points are. But I was concentrating on the failure of the health system to provide distributive justice. And I would, Dr. MKC, nothing else comes anywhere close to this. So please excuse me, I am not going to the 2 and 3. just this one.
Okay, we got a message. So what he is trying to say is failure of health system is a overarching problem under which all other ethical issues may be coming. That's what you are saying. Excellent. Now we'll take the physical aspect. You are the teacher. No, no. Shall I give it to you? I don't know. Okay, madam. The physical aspect, the physical as care of the patient. Physician, that's what I'm saying. Physician. No, 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 physician. That's what I say. You have been treating older people. What do you think are the three key cardinal points everybody should take home? Messages.
Cardinal,
In or problems in managing an elderly compared to a middle-aged
okay.
person. Simple
So,
as that.
most of the elderly persons who come here, if they have fever, they don't have fever, they come with altered sensory or confusion. So we will miss the diagnosis. Then second, we don't give priority to the elderly patients. In our state, we give priority to children. If the children get disease, they take the patient to KIMS. If the older person gets disease, they are brought to Thiruvananthapuram Medical College, not immediately, 1 or 2 or 3 days later. So the priority is not the elderly person. Then the third person, most of the time, patients come with electrolyte imbalance. And that's it, 3 points.
I think excellent. I think it's excellent because you said they may have they come with fever which may not be properly diagnosed when they come.
No, if they have some infection, they will not come with fever.
They will not have fever. Okay,
they
that's
will
the
come
point.
with altered
Unlike a
symptom.
middle-aged person, elderly person may not have fever. That's the key point you have said.
yes.
Okay, number 2, you talked about the priority.
Yes.
Okay, Neil.
Okay.
And number 3, you talked about
Electrolyte
electrolyte imbalance, which is normally not recognized unless you specifically look for it. Excellent 3 points. Madam, what you would like to add?
Sir, if you are thinking of the problems of the elderly in broad terms, one is multiple comorbidities or multiple problems. Second is they'll have multiple polypharmacy also usually, and they may not be able to convey everything what they are having. So I was thinking about the people who are going to give the care for the elderly. So the people who are going to give the care for the elderly should be trained to understand these problems, because when there is a polypharmacy, you have to decide which drug has to be given and what should be the dose and all those things. And also for the multiple problems, how we are going to manage it. One should not be making him lie down or bedridden or something like that. So there should be a training for the people who will be taking care of the elderly. And another thing is important is the compassion. Always the carers should have compassion, because compassion itself can produce physiological changes and maybe helping the people, and compassion can be trained also. So that who gives the care and how is also very important, because when I was a PG student itself, there had been always saying that we have to start geriatrics, but what we see now is that we are developing the infrastructure for the for the elderly people, so that they will not fall and things like that. The other aspect, giving care, is mostly it is neglected, or it is not being taken care of like as they should be.
Thank you. I think you have given 3 important points. She talked about multiple comorbidities, same thing Kichu was trying to say. Second, you talked about polypharmacy, which is literally practiced. Older people eat, sir, you said about 4 or 5 drugs. Actually, people here eat 10, 12 drugs. That is minimum 10, 12 drugs. That is what is happening. And the third one, madam said, is absence of compassion, not only from the part of the physicians, nurses, and the medical community, the family itself. The family itself. You understand? I don't know why children are aware of all this. My 8-year-old grandchild said, Appu, you may be smart and all that now, but one day, മൂലക്കിരുത്തു എന്ന് പറഞ്ഞു. ഞാൻ ഞെട്ടിപ്പോയി, എവിടുന്ന് ആ വാക്ക് കിട്ടിയെന്ന്. She is warning me, telling me that be careful, വയ്യാതാവുമ്പോൾ അപ്പുവിനെ മൂലക്കിരുത്തു എന്ന്. കിട്ടിയാ? That means children, എവിടെയോ കേട്ടതാണത്. But sometimes children are also thinking of all that. So that's the 3 points. Now, okay, now the real medical expert, Sir, please. What are the points that comes to your mind?
I'm facing mainly the elderly people with anemia. That's a main problem because the difficulty in making a diagnosis in elderly people, but they not be symptomatic much and unrecognized conditions in elderly people. Like a lot of people are coming late in the OPD with multiple myeloma, അല്ലെങ്കിൽ bone cancer, other malignancies. They are reporting late without making a proper diagnosis, prostatic malignancy, multiple myeloma, and this is simply for anemia, evaluating, treating with iron and other drugs. That's the one problem. Then the main problem is the nutritional aspects of the. There will be a lot of the food will be denied or should be given, or that's a nutritional aspects. I would like to say that give priority to the elderly people.
Maybe my lack of knowledge. Is the anemia so simple as iron?
It's not iron deficiency anemia alone. Yes, because ideally there should be a hematological programs for the elderly people. Anemia, the hematological, because it's high time that the malignancies are very common in elderly people. We have to find out the reason for the anemia, and early detection of the malignancy is very important.
No, anemia, I think we'd like to have your opinion. Is it an issue? And if it is issue, how do you manage? In children, we know we give and syrup and all that. It won't work in old age. That's why.
No, I think there's a thing in geriatrics or in any medicine, three most important things. You asked for the three most important things. The first important thing is diagnosis. The second important thing is diagnosis. And third important thing is diagnosis. You happy with that?
Yeah. I'm happy.
So that's what the old patient said, you know, if you have pain in the left knee, why don't, on the right, it's not age, there is some diagnosis. So if patient comes with anemia, it could be iron deficiency, it could be folate deficiency, it could be myeloma, it could be anything else. So that's, I have seen patients coming with anemia, getting iron transfusion, they don't get better. So, because there's no diagnosis to begin with. See, yeah, so diagnosis is very important. And unfortunately, older people don't read textbooks. They have infection in the urinary system, they come with confusion. You know, they have any electrolyte imbalance, they come with confusion. So anything, you need a proper diagnosis. If you don't make the diagnosis, you don't treat them. They may have acute cholecystitis, and they don't come with the right hypochondrial pain and shoulder tip pain and fever and chills. They come with confusion. Because as aging happens, your physiological reserve will diminish. So any stress on the reserve and the brain will make you to have delirium. In our teaching hospital, major tertiary hospital, you know the hospital, John Hunter, the common condition, all the people come with confusion. And when you diagnose, they may have either anemia, they may have infection, because they don't have immunity. So they don't have a fever when they get an infection. So diagnosis, diagnosis, diagnosis.
Thank you, sir. You're saying it's only a external symptom. It's not a problem. Problem need to be identified. Yeah. Excellent. I am aware of two major studies. One, a national study of adolescent, my subject adolescent will come. Old age, elderly people, in which Thiruvananthapuram also a part of it. And there is a whole lot of, little old, but it gives a lot of information. There is another study done by Dr. Rema Devi and group. That is a beautiful study, you know, who was trained in Newcastle. And she has done a study for the government on elderly and all their problems, psychosocial, economic, socio-economic, not only medical, every problem. I think these two documents may be preliminary looking at it. It may not be highly academic, but it is useful to tell us what happens here. Now, I don't want to restrict to this group, people sitting here, because people sitting there are more higher educated. Can we have some comments from you, sir? Just give the mic. രണ്ട് മൈക്കുണ്ട്, സോറി. എൻ്റെ രണ്ട് മൈക്ക്. Old age? Sir, he's saying old age. 3 points. On ആക്കിയില്ല sir. ഒന്ന് on ആക്കി നോക്കൂ.
Older persons, you don't treat the disease, you treat the persons. So as Rajagopal has said, if they have cancer or something like that and he is going to die, or Radhakrishnan has said, patient has got renal failure, you only do dialysis and other things. It's not the treatment. Treatment is for the person. One, geriatrics. Two is, it should start from very free, early treatment, futuristic treatment or upstream treatment, So you are going to get older, you are going to get all these diseases like diabetes, pressure, all those things. You can prevent them. Look at that telomere. Your telomere is getting damaged, so start the treatment for geriatrics from the beginning so that you don't get that disease. Can prevent the diseases that will disable you when you get aged. Because as we know that, you get older earlier because of your gene, only partially. It's all the biological factors like, Third one is older people have some types of diseases, as has been said. We see a patient coming with, sudden onset of delirium. We have to exclude dementia, delirium, or we have to find out the cause. So to differentiate between delirium and dementia, and if it is delirium, treat it immediately, the patient gets better and go home. So those are the 3 points. So there should be an update for all doctors.
Thank you, sir. Thank you so much. One sec. There is a little difference of opinion, see here. On one side, he emphasized diagnosis. On the other side, we are saying treat the patient, not the disease. So for example, suppose I say, don't bother to do all the investigation on me, just let me be without all your testing. Lots of people now say, don't try to do this, don't try to do that, don't leave me alone. Which one would be the appropriate one in here?
I think that's the best thing, because that's the best thing we should choose, because they know what they want, we can, they should be allowed to take their decisions.
Anybody on legal aspect, good in legal aspect? Hari is good in legal aspects. Can we make such a decision like that? Can we say? Autonomy is there, yes, but can we escape? We didn't.
Patient has to be respected. His views has to be
Sir, I agree with all that. I am just asking a question. Do we have a legal protection for that?
legal protection has to be made.
Because we are going to have a unit. We are going to have what? Yes, sir. You want to answer?
In a Supreme Court verdict of 2023 January, less than 1 year old, in the absence of law covering end-of-life care, the Supreme Court has given a clear indication that advanced medical directives given by the person should be followed. It's binding on you and me. And so this is all, for all of us to remember, we have to say, he mentioned earlier, quality of life versus quantity. What do you want? I guess almost everyone would want the same thing as I, like some quality, not just stretching out the dying process by 3 weeks in an intensive care unit. It is legally valid. Advanced directives are to be respected. Autonomy, the fundamental ethical principle, is underlined by the Supreme Court verdict.
I wanted that to come out. Sir,
One more word.
I want-
If you treat this patient, can you definitely say that treatment will improve him? Usually you get, because of the treatment, the patient is suffering and all those things. So I think we should leave it to the patient.
okay.
Thank you.
Sir, nephrology point of view, you must be having the maximum number of elderly with chronic renal failure and whole lot of problem. Actually, I was asking about anemia in that context. Is it because of something to do with renal that
that with an example. We have two people, aged 68 years. One is a male weighing 70 kilograms. The other is a female weighing 40 kilograms. The kidney function of that male weighing 70 kilograms, assuming his creatinine is 1, which is normal, he will be 70 ml per minute. The same creatinine in a underweight lady who is aged 68 kilograms and having 1 milligram creatinine will be only 35 ml per minute. And the drug has to be modified. This is not really relevant for patients, it is relevant for me and you. We are all about 70 years or 60 years anyway, and except probably Srinath. Yes, not that 70 anyway. Anyway, so I think one point is that the physicians or the clinicians as well as the patient should be aware that as age increases, the dose of drugs have to be reduced. I know that many people among us get the antiviral drug called oseltamivir, 75 milligram daily for 5 days for any viral infection. The dose has to be reduced for a renal failure patient. For a renal failure patient, the dose of oseltamivir is that for a patient on dialysis is 30 milligram every alternate dialysis, only 30 milligram. You can't give 75 milligram BD. We see so many patients with 75 milligram BD, those coming with renal failure. So that is point number one. This second point is pill burden. I'm seeing prescriptions of 18 to 20 different drugs because a patient comes to a multi-specialty hospital, cardiology consultation, 5 drugs, gastroenterology consultation, 3 drugs, nephrology consultation, 3 drugs, and then pulmonology consultation, nebulization, blah, 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 and then another way. So
course,
That's
that
the
of course.
biggest
The interactions, I don't have time for the interaction. The third thing I want to talk is about the lack of physical activity in the hospitalized patients. They just remain in bed, develop sarcopenia as we had just now. In 2 weeks' time, they are unable to walk. And one point is vitamin D deficiency is so common in old age. I give vitamin D blindly without checking the vitamin D level. I take vitamin D because one of my close relatives had vitamin D deficiency and we are taking the same food and same activity. So if so-and-so has got vitamin D deficiency, why not I? I've been taking
any
for 5
comments
years.
on B12, sir?
B12, of course, it comes in the diet only, but once in a way some vitamin B tablet, okay. But vitamin D, I have been
Neurologist-
taking 60,000 units every month for the last 8 or 10 years.
Okay. Pulmonologists, actually, most of the problem of older people are related to lung. They can't breathe.
Thank you, MKC, for giving us, all of us, a chance to highlight sharing our experience with the reference.
3 points.
Yeah, okay. Because most of the points has already been brought in. Important one, number one, is safety profile, because Dr. Kashi said polypharmacy, naturally, because there is drug interaction and there is modification. Yeah.
Specific to pulmonology.
Then it is the another one, Dr. Rajagopal said, the equity. Nobody is giving any priority for the elderly when compared to other population. So actually there requires a priority care in the diagnosis, the prescription and the monitoring, because once you start a drug for this age, and they have to take it a long period of time. Unlike the antibiotics, other things, you can discontinue the drug after 2 weeks or 3 weeks. But pulmonology patient on any particular drug, for example, a bronchodilator or a chronic bronchitis, they have to be on that drug for the remaining part of their life. So the personalized prescription, that is most important for elderly patient.
That's a good
That
point.
is
Personalized prescription.
prescription.
Any other chronic problem that you face in among your elderly patients as a pulmonologist?
The neurocognitive dysfunction is the most important thing because they themselves cannot administer these things. That is why we are recommending the nebulization. You see, nebulization, once the care is there,
Great.
naturally that will be giving immediate relief and the patient will be having a better quality.
There are so many senior people. Please, please come forward. No, it's a free for all. Don't worry. We are just sitting this side doesn't mean anything. Only 3 points, but no description. 3 points.
So I have only one point.
That's
Among
very-
the major symptomatology that you said, among giants, isn't constipation a major problem, sir? Which I thought was not included in your major symptomatology. You said anorexia, frailty, etc.
In Kerala is a big problem.
Can I?
Any solution for constipation? So we want
Mine different.
some tips also. Any solution anybody can say for constipation? Eh? Sir, just doesn't work, sir. This all we can say, but old people don't write nothing. A simple solution, സാമ്പാർ ചീര എന്ന സാധനമുണ്ട്. എന്തുവാണ്? സാമ്പാർ ചീര വേണ്ടത്ര കഴിക്കുക. എല്ലാ വെജിറ്റബിൾ എഫക്റ്റീവ് അല്ല സാറേ. സാമ്പാർ ചീര എന്ന് പറഞ്ഞ് കട്ടിയുള്ള സാധനമാണെന്ന് കഴിച്ചു നോക്ക. Your tomorrow morning your life will be so good.
Taking adequate amount of vitamins C, they will not be having any sort of consequences. What all people say is have to not. You have to have
No. Point is, sir, I'll tell you, we just giving 3. Sir, one sec. We are only suggesting 3 or 4 simple things which will work. It need not work for everybody, but that's a choice that you are giving. You try this, you can try this, you can try. That's all what I would say. Because elderly people, we all talk about good food, this, that, and all. Hardly they eat even. So how can you have so? Yes, sir, please.
I think it's very good.
പക്ഷെ അവർക്ക് ഡയബറ്റീസ് ഉണ്ടായിരിക്കും, അവർക്ക് ഷുഗർ പറ്റൂല, ഒരുപാട് പ്രോബ്ലംസ് ഉണ്ട് സർ. Okay, sir, please.
Yes, sir. Dr. Radhakrishnan, my same batch, there were 5 Radhakrishnans. So each person had a nickname. So his name was representative. So Radhakrishnan, you see, in older orthopedic trauma textbook, Watson Jones jokingly written, through the pelvis you come, and the same thing you go, meaning fracture neck of femur. So sitting here with BRK, I had a bit long, 10-year experience of treating fracture neck of femur in Trivandrum Medical College and later in Kochi. So unless it's an interdisciplinary approach, it's finished. For the orthopedic surgery, it's only 45 minutes. Sometimes
Got it.
I did 30-35 minutes, I do a fixation. But what about the rest of the, period of case? So in Australia, is it same, the neck of femur is, again, they go through the pelvis?
Thank you, sir. Thank you, sir. We got a message. We have cancer experts sitting there. Would you like to say something? I want your specific comments on 2 things. One, particularly on prostate cancer.
Okay.
We are having people who miss it for a long time and then come with multiple, secondaries and whatnot.
Yeah.
Is it a huge problem?
Prostate cancer is a rising problem in Kerala. As the age advances, prostate cancer is there. But one good thing is that the natural biology varies between the different. So you have to diagnose it, what type of, whether very aggressive tumor or a very indolent tumor.
What should a common man do?
Yeah,
to make sure that I don't have that? What should he
they
do?
had to go for a screening. If they
PSA.
discuss with the doctor and they will go for a screening if necessary, PR examination, PSA is the simple thing you can.
PSA is good enough.
Yeah, good enough for a
Okay.
screening. But the
That-
problem is the diagnosis with the I rise to PSA, and then there's a problem. So even with a low grade prostate cancer,
Yeah.
even with the PSA, we can diagnosis, we can go for a surveillance study. It won't change the life expectancy of the patient.
So I am asking
Yeah.
for myself,
Yeah.
suppose. What will you tell me?
PSA.
Can I be happy with PSA
Yeah.
result? Okay, that's
Yeah.
that's the message.
And another thing is malignancy is increasing in old age and the expectancy. What is your expectancy? Usually you go for the shared decision. with the-
Multiple myeloma, second one I want to ask.
Okay.
They have been getting lot of Ayurveda treatment for back pain, and one day you find
that's
it is
true.
multiple myeloma.
That's true, sir. That's true, sir. Many people, even young people, they come with an advanced stage of multiple myeloma after Ayurvedic treatment. Recently, one patient, she had the Ayurvedic Thiruvananthapuram for a spinal.
Same.
Yeah, same. It's a common thing, sir.
Okay, okay.
Yeah.
Radiologist, what do you
Then-
say? You are doing do you believe in doing lot of MRI scan and all the older people? Very old, whatever you call that. Is it good? Or you're just looking for something you find which has no significance?
No, only when it is indicated, we can do that. But some problem with the technical problem also.
Yeah,
will
that's
be
what I
there.
wanted to say. That's what I wanted to
The
say.
old age people may not be very comfortable in lying in the
And with that noise.
Yeah, claustrophobic environment. So that there will be a difficulty in getting adequate imaging in the old age also.
But I'm told there are now
we-
MRI scan
yeah.
without that noise.
Yeah, even if there is no noise, the claustrophobia is there.
Okay.
So which is more in the old age. No, open MRI is inferior to the closed MRI because the magnetic strength is very low. Yeah.
Gastroenterologist? Any gastroenterologist here? Sir? Oh, sir. Sorry. Sir, whole lot of people have this old age has acidity problem. What is your comment on unnecessarily using too much of omeprazole and all that? Is it good? I am told it can damage the kidney. Sir, Kashi sir. Which one? Pantoprazole, omeprazole group. Okay. So that's a key point, Madam, just right. That's a very key point. I wanted that point to come forward. I think we unnecessarily use, sir, please. Hey, ഒരു മിനിറ്റ് ഞാൻ ഇത് കംപ്ലീറ്റ് ചെയ്യില്ല ഒരു മിനിറ്റ് ഇതിന് എന്ത് ചെയ്യാം അസിഡിറ്റിക്ക് വേറെ എന്ത് ചെയ്യാൻ പറ്റും നിങ്ങൾ ഇങ്ങനെയൊക്കെ ഫിലോസഫി പറയും പക്ഷെ അസിഡിറ്റി വരുന്നു കിടക്കുമ്പോ ഇത് വരുന്നു എന്തോ ചെയ്യണം എന്തോ കഴിക്കണം
I would like to give some general comments, then I will come to the specific points, But the general comment is that, I feel that aging is a crime in the society which is resource poor. So I think unless you have for resources and unless you're willing to invest your resources, the old age becomes very miserable. That's the first point that I would like to. So I think that our society, we need to. The aging, in fact, is a phenomenon which we have to accept, and then we need to find out the resources and we need to invest the resource upon them. So that's the first point, to make them happy. So I think if you're healthy, your old age is going to be happy. And if you are less resourceful and less healthy, it's actually misery to prolong your life. So that's the first thing. What we need to do, in fact, we need to. So all these points which you're asking for. So there are actually chapters on geriatric specialty. So all the specialists, I would like to encourage these people to focus more on the geriatric chapters. For me, the geriatric gastroenterology and the geriatric hepatology.
I think it's a fantastic point that you have said.
And the nephrology.
Just like children, in the textbook of medicine, there should be 4 or 5 pages of geriatric one. Excellent.
All the specialty, I'm very sure. Cardiology, gastroenterology, and everywhere. The geriatrics are there. So that, in fact, is not actually properly read, practiced. And so that has to be trained. So this is the training. So we need to have training. We need an attitudinal training. And we need to have medical training. And then, as initially
Kavita?
discussed, there should be statutory support as well. We need to have statutory support.
Thank
as
you.
well.
Anybody else want to make comments, sir, please? Please, sir. Let after him. He has asked for 2-3 times.
Take care of. He was talking about the failure of the health system. What I want to ask is, as far as Trivandrum Medical College is concerned, what type of geriatric care is now available? Anybody can comment? Okay.
What actually the regional geriatric center was set up there in Trivandrum Medical College. So what we are giving is tertiary care. All the patients who are referred from periphery, they are admitted to, we have a 30-bedded area, regional geriatric center, where we admit that 30 patients and look after them. It's looked after by the physicians. So there's a difference being looked after by a physician and a geriatric. We have 6 units in medicine and we admit patients there and the patients are looked after by the physicians. And we have physiotherapy also. We previously, before the COVID, we had 2 medical officers and social worker, everything to liaison with the peripheral hospitals for transferring the patients. And we had a physiotherapist. They used to look after the patient very well. But after the COVID, we have only a physiotherapist and 1 nurse, trained nurse.
You mean we have a specialized geriatric care unit?
You cannot call it a real geriatric care.
That's exactly what I was trying to, because we don't have a geriatric practice as such existing in Kerala or in India.
No, or the geriatric care has been usurped by the physicians.
See, every physician is looking after, or every healthcare except the pediatrician, they are all looking after the aged also.
Okay, that's it.
And the question out here for the oration was unmet needs of geriatric practice. Which are the areas we are missing in? Well, as such in Kerala or in India, because of a lot of constraints, we don't have that sort of specialized division.
So,
but we are trying to improve. What else could
who
be
all
done
want to make
the practice?
Just 1 sec. 1, 2. Who all want? 3 people. Anybody else, sir? 4 people. Anybody else? 5. Okay, one point each. 1 point each. I think.
So again, I think there is a question of chronological age and the biological age. Whom to treat? Whether you need aggressive rhythm control, bring him back to sinus rhythm with proarrhythmic drugs, or just control the rate and accept atrial fibrillation with just rate control, beta blockers and other things. So I think it again depends on the biological or chronological. If you think that the patients are also well informed. So I would try to, many of them I have actually brought them to sinus rhythm and they are doing well. But certain people, I feel that almost end stage and other thing, I just accept a rhythm control. Only I may rate control by only controlling and giving some palliation. The second thing is we see a lot of elderly people who come with issues. We find that they have developed the ECG suggests silent myocardial infarction. They are not aware or it passes out gas. Dr. Matthew Roy was an astute physician. He was also having gas. But unfortunately, we couldn't get an ECG on him to diagnose this. Very unfortunate. So I mean, now I think the knowledge expansion is so much that people are tuned to gas. I think it should not be overlooked, particularly the elderly
Got
people.
the point,
They come
sir.
with.
Thank you, sir.
Okay.
Next. 1 minute. I think we are already running late. I was supposed to stop at 8 o'clock. It's only 2 more minutes. Please.
Sir, we all know that the quality of life of the elderly people have to be improved. For that, definitely.
But I don't find any elderly here. That's the problem. Okay.
Definitely, the role of dentist must be stressed because.
Yeah, excellent. Excellent.
Because
you need
without,
to have teeth if you want to eat something. Yes.
I believe that with medicine alone, you will not be able to treat all the diseases. The food we take is also very important in treating diseases.
Okay.
So I represent the dental
I understand.
fraternity, prosthodontist and
It's a
implantologist.
great researcher in dental. I know.
And I have already given a proposal for starting geriatric dental clinic in
Sir.
dental college, but
Thank
it
you,
was
sir.
not
Thank you. Excellent.
materialized.
No, it will come. Don't worry about it. Sir, last comment. Your comment. 1 minute.
Middle Travancore. Most of the families, only 2 members is there. Old lady and then children abroad. Nobody is there too. So accessibility to healthcare is a problem. So we have a definite healthcare program for geriatric people so that we can go to the doorstep rather than hospital-based geriatric care.
Yes, your comments. Your comments. Your comments, sir.
സാറ് രണ്ട് കൊനസ്റ്റ് ചോദ്യമാണെന്ന് പറയരുത്.
അതേ ചോദിക്കത്തുള്ളൂ, എനിക്ക് അറിയാം.
One is where are we now in research in the process of retardation of our aging process? That is one. The second one is thinking on that point in the diametrically opposite side of ethics. Are we really going against ethics because the already born people are in a process of living for a longer time, preventing the younger generation to come into the world? So decreasing birth rate means many people who are likely to be born in the world is being prevented just for the sake of who are already being born. The birth rate, we are decreasing the birth rate only because we are here. So this is a diametrically opposite side of ethics.
The aging process.
Yeah.
We are all improving, we are all aging. That itself is a prohibition. That itself is going out.
You can answer. If you understood, you can answer.
No, Hari, I just want a clarification. Hari, are you meaning that care of old age is taking up resources which are better spent for the younger people? Do you mean that? Yeah.
People are not being allowed to be born in our world because we are here. Yeah, the birth rate, we are purposely decreasing the birth rate only because we are here. The population is increasing.
Highly philosophical.
Old age population has nothing to do with the procreation. You see, in that way, what you said is not true.
Principal, madam. Madam, you can make a comment before we take some questions from the audience. Madam, you read it. Kavita, please, madam. One sec. Please.
Sir, I agree to the statement that just because the geriatric population is increasing, that doesn't mean that the younger generation cannot come up. In fact, the younger generation are leaving the country. All those present are just leaving the country for better prospects. That's what they say, for better economic prospects. Okay. And so we are left with the geriatric population. That's the truth.
Okay, now Kavita will read some questions others have asked.
Yes, sir. We have some participants on Zoom. There's only one question, sir. Sambar chira. Is it same? Is it same as Mysore chira or Velli chira? No, Dr.
Same അല്ല അതിന് ഞാൻ ഒരു ആൻസർ 2 മിനിറ്റ് പറയാം. ആദ്യമായിട്ട് അഡോളസന്റ് ഞാൻ ചെയ്തത് 30 കൊല്ലത്തിന് മുമ്പ് ഒരു സ്ഥലത്ത് എന്നെ വിളിച്ചപ്പോൾ ഐ തോട്ട് ഇത് അഡോളസന്റ് ആയിരിക്കുമെന്ന്. അവിടെ ചെന്ന് കഴിഞ്ഞപ്പോഴാണ്, എവിടെയാണെന്നും പറയാം, പേരൂർക്കട ഒരു കോളനി ഉണ്ട്, അതിനപ്പുറത്ത് കുറച്ച്. അപ്പോൾ അവിടെ ചെന്നപ്പോൾ എല്ലാം 70 കഴിഞ്ഞ ആ പാട്ടുകളാണ് ഇരിക്കുന്നത്. ഞാൻ പറഞ്ഞു ഞാൻ എന്തോ ചെയ്യാൻ പറ്റും, ഞാൻ പീഡിയാട്രീഷ്യനാണ്, ജെറിയാട്രിക്സ് ഞാൻ ഒന്നും ചെയ്തിട്ടില്ല. പക്ഷെ എനിക്ക് അങ്ങനെ തോർത്തു കൊടുക്കുന്ന ഇഷ്ടമല്ലാത്തതുകൊണ്ട് ഞാൻ ഒരു സെക്കൻഡ് ഒന്ന് ആലോചിച്ചു, എൻ്റെ അപ്പൂപ്പൻ പറയുന്ന പ്രോബ്ലം എന്താണ്, അമ്മൂമ്മ പറയുന്ന പ്രോബ്ലം എന്താണ്, വീട്ടിലെ സാധാരണ എൽഡേഴ്സ് പറയുന്ന പ്രോബ്ലമാണ്. 4-5 പ്രോബ്ലം ഐഡന്റിഫൈ ചെയ്തു. അതിലൊന്നായിരുന്നു ഇത്. ഏത്? എപ്പോഴും നെഞ്ചരിച്ചിൽ. അതിന് ഒരു സൊല്യൂഷൻ ഞാൻ പഠിച്ചത് ഹൈദരാബാദിൽ നിന്നുള്ളതാണ്. അവിടെ ഈ മുളക് തിന്നുന്ന മല്ലിയില അരച്ച് ചമ്മന്തി കഴിച്ചാൽ മതി. ആയുർവേദമാണോ ഒന്നും വിചാരിക്കേണ്ട, ഇത് ഹോം റെമഡിയാണ്. അതിന് ഇറിറ്റേഷനും വേണ്ട. മല്ലിയില ചുമ്മാ മല്ലി തിന്നാൽ മതി. നമ്മളിങ്ങനെ കിടക്കുമ്പോൾ നെഞ്ചരിച്ചിൽ ഹാർട്ട് ബേൺ വന്നാൽ മല്ലിയില ചമ്മന്തി ഒരു കോസ്റ്റുമില്ല. അല്ലെങ്കിൽ നമ്മൾ കഴിക്കുന്ന സാധനം ഇഷ്ടമുണ്ടെങ്കിൽ കഴിക്കുക, പക്ഷെ ദാറ്റ് ഇസ് എ ഗുഡ് വൺ. രണ്ടാമത് അവർ പറയുന്ന പ്രോബ്ലമാണ് കോൺസ്റ്റിപ്പേഷൻ. അതിനാണ് പല സൊല്യൂഷൻസ് ഉണ്ട്, പക്ഷെ ഏറ്റവും എഫക്റ്റീവായിട്ട് ഞാൻ കണ്ടത് എന്തുവാണ്? സാമ്പാർ ചീരയാണ്, തിക്ക് ചീരയാണ്. അത് കഴിക്കാൻ നമുക്ക് ഉള്ളിത്തിങ്ങി നേരെ കഴിക്കാൻ പ്രയാസമാണ്. മീൻ കഴിക്കുന്നവരാണ് അതിൻ്റെ കൂടെ കഴിക്കാം, അല്ലെങ്കിൽ പിക്കിളിൻ്റെ കൂടെ കഴിക്കാം, എന്നാലും അല്ലെങ്കിൽ കഴിക്കാൻ പ്രയാസമാണ്. പക്ഷെ ഐ തിങ്ക് ഇറ്റ് ഈസ് എ ബ്യൂട്ടിഫുൾ വൺ. അവിടെ മൂന്നാമത്തെ പ്രോബ്ലമാണ് മുട്ടുവേദന. അതിൻ്റെ മെഡിക്കൽ സൊല്യൂഷനൊക്കെ വേറെ ഇരിക്കട്ടെ. മുട്ടുവേദന കുറയ്ക്കാൻ ഏറ്റവും നല്ല മാർഗം വെസ്റ്റേൺ ടോയ്ലറ്റ് ഉപയോഗിക്കുക. സാധാരണ ബാക്കി എല്ലാത്തിനും ഞാൻ ഇന്ത്യൻ എന്ന് പറയും, ഇതിനകത്ത് മാത്രം വെസ്റ്റേൺ. താഴെ ഇരുന്ന് കഴിഞ്ഞ് കുത്തി ഇരുന്ന് എണ്ണിക്കുമ്പോൾ ഉള്ള ഷിയറിംഗ് ഫോഴ്സ് ആണ് ഈ സ്ക്രാച്ച് മുഴുവൻ ഉണ്ടാക്കുന്നത്. ഇതൊക്കെ ഭയങ്കര എഫക്റ്റീവായിട്ട് കണ്ടിട്ടുണ്ട്. അതുപോലെ തന്നെ തലകറക്കം, അവിടെ ഏറ്റവും വലിയൊരു പ്രോബ്ലമാണ് തലകറക്കം. അതിൻ്റെ സയൻറ്റിഫിക് ഒന്നും അല്ല ഞാൻ പറയുന്നത്, ഞാൻ ചെയ്യുന്നതുമാണ്. രാവിലെ എണ്ണിച്ച ഉടനെ കൈ ഇങ്ങനെ വെച്ച് ഇടത്തോട്ട് വീഴുക, വലത്തോട്ട് വീഴുക, മുമ്പോട്ട് വീഴുക, പുറമോട്ട് വീഴുക. അതിൻ്റെ എന്താ വെച്ചാൽ സെമി സർക്കുലർ കനാൽ ഫ്ലൂയിഡ് തിക്കാവും, അത് സർക്കുലേറ്റ് ചെയ്യത്തില്ല. അതുകൊണ്ടാണെന്നാണ് പറയുന്നത്. ഓഫ് കോഴ്സ് വേറെ ഒരുപാടുണ്ട്, ബ്ലഡ് ഫ്ലോ കുറഞ്ഞതിൻ്റെ വരെ ഒരുപാട് കാണും, അതൊന്നുമല്ല. പിന്നെ രാത്രി നല്ല ഭംഗിയായിട്ട് കാല് വേദന വരും, കാഫ് മസിൽ പെയിൻ ഭയങ്കരമായിട്ട് പിടിക്കും, കാഫ് മസിൽ കയറി പിടിക്കും. നന്നായിട്ട് കവർ ചെയ്ത് കിടന്നാൽ മതി, ഒന്നും വരത്തില്ല. നമ്മൾ AC ഇട്ടിട്ട് കാല് കവർ ചെയ്യാതെ കിടന്നു കഴിഞ്ഞാൽ നാച്ചുറലി യു വിൽ ഹാവ്. അതിൻ്റെ ഇലക്ട്രോലൈറ്റ് ഇംബാലൻസ് കാണാം, ഒരുപാട് പ്രോബ്ലം കാണാം. ദീസ് ആർ ഹോം റെമഡീസ്. നമ്മുടെ ഓൾഡർ ഏജിന് വി ഷുഡ് ഗോ ഫോർ സിമ്പിൾ ഹോം റെമഡീസ്. അല്ലാതെ എല്ലാത്തിനും മെഡിക്കേഷൻ്റെ ആവശ്യമില്ല. പക്ഷെ എന്ന് വിചാരിച്ച് ഇത് ഗോസ്പൽ ട്രൂത്ത് ആയിട്ട് എടുക്കണ്ട. യു ക്യാൻ ട്രൈ ഇറ്റ്. കൊള്ളാമെങ്കിൽ എടുക്കുക, ഇല്ലെങ്കിൽ ഐ ആം ഷുവർ ഒരാഴ്ച കഴിയുമ്പോൾ ആരെങ്കിലും എന്നെ വിളിച്ച് ഒരേ കൊള്ളായിരുന്നു കേട്ടോ എന്ന് പറയും. അറ്റ്ലീസ്റ്റ് ഫോർ ദ കോൺസ്റ്റിപ്പേഷൻ. Even if you don't say, your wife will come and say it's made life easier.
It was an excellent debate on the geriatric practice. The postgraduate secretaries are
ഞാൻ ഒരു കാര്യം പറയുമ്പോൾ സ്പെസിഫിക് കേസ് ഇൻ മൈ മൈൻഡ്. ഒരുപാട് ഞാൻ പറയുന്നു. അപ്പൊ ഇതാണ് കാര്യം, അത്രയേ ഉള്ളൂ. അത് മിക്സ് ചെയ്ത് പോകുന്നു പറഞ്ഞത്.
So before we wind up, there are some suggestions we got online, which I feel are very important. One suggestion is that the screening of geriatrics is not the elderly, irrespective of the department of admission is required. So we have already discussed about that. We need to screen. So this is some of the suggestions which
അത് 5M ആകാം, 5I ആകാം, എന്ത് വേണേ ആകാം.
Exactly.
Do something.
Yeah.
Okay.
So we need to screen these people, for a better care. The second suggestion is that training of undergraduates and postgraduates on the geriatric principles. So this is what is already highlighted. We need to emphasize on the training programs,
ചുമ്മാതെ ട്രെയിൻ ചെയ്താൽ
So this
പോരാ.
is only
അവരെ
suggestions.
ഞാൻ
Yeah,
പറഞ്ഞു
suggestions.
അവരെ ഏതെങ്കിലും സെന്ററിൽ കൊണ്ടുപോയിട്ട്
sure.
അവരുമായിട്ടൊന്ന് സംസാരിക്കണം.
So we need
അല്ലെങ്കിൽ
to,
കുട്ടികൾക്ക് ഐഡിയ കിട്ടത്തില്ല.
definitely we need to highlight, we need to emphasize the training
Okay.
in the undergraduates and postgraduates. The third is the role of family physician is not highlighted here. So he feels that it's all from different points, different persons,
Excellent
So the
points.
family physician concept has to be there for the geriatric care. The next is retaining of already passed out doctors with no geriatric education. So he wants to retrain the doctors, because the population is aging and geriatric problems coming up, and the already passed out doctors might have missed the opportunity, and he needs retraining of these people. And the last one is that,
റീട്രെയിനിങ് ഇല്ലെങ്കിലും സ്വന്തമായിട്ട് അനുഭവിച്ച് പഠിച്ചോളും.
okay, the last suggestion is that, the holistic integrated approach is better for the elderly. So I think these are the online comments which we have received. So thank you very much.
I have a good news. Professor of Medicine, Madam has agreed to put all this point together and come out with an article. Yes? Yes. She has agreed. Or I make her agree. And it will be published in Kerala, KGMCTA journal, somewhere.
Yes, that can be done with the help from all of you, sir. If there is any point, I can ask and discuss and do that. That can be done, but not very immediately. It will take some time also. Okay, okay.
രണ്ടാഴ്ച അല്ലെങ്കിൽ ഇത്രയും സീനിയർ ആൾക്കാർ ഇവിടെ ഇരുന്നു ആൻഡ് സോ മെനി എക്സ്പേർട്സ് ഹാഡ് കം. അതിനൊരു ഔട്ട്കം ഇല്ലാതെ ഈ മീറ്റിങ്ങിന് ഒരു ഇതുമില്ല. ആൻഡ് ഔട്ട്കം ഹാസ് ടു ബി ദെയർ. അത് മാഡം കുറച്ചുകൂടെ സയന്റിഫിക് ആയിട്ട് എഴുതണം എന്നുള്ളതേ ഉള്ളൂ. ഓക്കെ. ലാസ്റ്റ് വേർഡ് ഫ്രം കിച്ചു. Kichu, I know for last 30-35 years. 87, 88, I was in Australia. I have had lot of food in his house, stayed in his house for many days. And Usha had fed me so much. So I'm really, really fond of him. I called him to the university. By the way, even before all these people thought about university, as a vice chancellor, I had started a course on geriatrics. It is, now I don't know whether it is there or not. Lots of people passed that. And for him, you had come as faculty. You remember?
Yeah.
Yes. Okay. Last word from me and we discuss.
No, it's very interesting and exciting to hear what you are deliberating today. And I would love to come back and help you if I can. Yeah.
Thank you. Rajagopal sir will say the last word. അതുകൊണ്ടാണ് സാറേ ഞങ്ങൾക്ക് എല്ലാ സാറിന്റെ ആവശ്യം വരും. അതുകൊണ്ടാണ്.
ചിരിച്ചവരെല്ലാം ഒന്നുകൂടെ ആലോചിക്കണം. അതെ, but I would seriously suggest that everybody should prepare an advance directive. This is mandatory. Now that it is legally sanctioned, you never know. But the most important part of the advance directive is not filling up the form. The form is available on our website, palimindia.org. The most important part is not that. The most important part is telling your children and explaining to them why this is important. Because whatever is written, doctors know that dead people do not go to court. Living family members go to court. So the advance directive will be practical only if the family agrees. Thank you.
So thank you all for this opportunity. I was supposed to disappear because of my throat was bad, but now the adrenaline has made me go.
Sincere thanks to Professor Chunaya for the enlightening oration, showcasing that age is not just a number. Sir, we look forward to having you very often. And my appreciation also goes to Professor Dr. Krishna Kumar, my own teacher, for bringing in our speaker and also for the very concise moderation. A special thanks to Professor M.K.C. Nair sir for that excellent moderation and also making the panel discussion very lively and inclusive. My heartfelt gratitude to Padma Shri Dr. M.R. Rajagopal, the father of palliative care in India. Thank you, sir, for your expert remarks. And thank you for all the faculty. Again, my own teachers, our own alumni, our own faculty, Professor Suma Madam, Professor Aruna Madam, and Professor Srinath sir for their remarks from their experience. And I extend my sincere gratitude to all the senior alumni present here who are in fact the regular and permanent attendees of any session conducted in this hall, and also to all our guests who have joined us on Zoom. And lastly, I thank the organizer, our Vinay Kumar sir, because his enthusiasm and motivation made this day for geriatrics possible. Thank you all. Let's all have a group photo